Yeah, thank you very much, Darina. And so, as you've said, I at the point at which I accepted the invitation to speak at this meeting, I was the clinical director for the London Dementia Clinical Network, and I'll show you some of the um, work that we did through the network. I've stepped down from that role and as of this week become the National Clinical Director for Dementia for NHS England. So this is the first time I'm giving a talk with that title. So thanks for having me. All right, these are my
Congratulations as well.
thanks. All right, so these are my declarations. Nothing on there is going to be relevant to what I'm talking about today. Are the slides advancing correctly? Yeah, good. Okay, so you've asked me to talk about young onset dementia. So let's just try and start with some definitions. What do we mean by this? So the definition of young onset dementia that most of us use is dementia where symptoms begin under the age of 65. Now, this is a completely arbitrary distinction, and it is based, I think, on the historical male retirement age. Now, that's obviously an irony, and not the only irony of this kind that we see in society, because, of course, most people with dementia are women. But we're using a male definition of the age cutoff for dementia. But that's unfortunately, how these things have gone historically. And because it's based on what has until fairly recently been a retirement age, it's a social distinction rather than a biological one. I think it's important to kind of sort of bear that in mind. But of course, age is an important biological variable in the way in which dementia presents and the underlying neuropathologies. But the distinction, I think, has been made for social rather than biological reasons. And it's just worth reflecting that this cutoff of 65 probably is losing its valence, because since 2011 in the UK, there's been no legally enforceable retirement age, and the pensionable age, the age at which you can claim your state pension, it keeps changing. And I've just put there, because I've looked this up this morning, what has been happening to the pension age, and the age at which everyone presumably on this call is going to retire, unless you're lucky enough, Audrey, to have retired, is definitely not going to be 65. At least the age you're going to be able to access your state pension is definitely not going to be 65. It's going to be 67 by 2028, and it's probably successive governments, I suspect, will try to push it higher than that as the population ages. And so maybe what we're talking about would be better defined as working age dementia. Maybe that's a better term, but it's also a flawed term because it kind of reduces this distinction to one that's purely about whether people are in work or not. And of course, there are many other ways in which this construct of young onset dementia might be different to late onset dementia, and we might define it not necessarily around work, but around perhaps whether you've got childcare responsibilities, or so there may be other domains that we want to capture when we think about what the uniqueness of young onset dementia is. So how much YOD is there? So if you look at the recorded cases on GP dementia registers, there's actually only 15,000 people in England who are aged under 65 who have a recorded dementia diagnosis. And that is about 3% of the total number of people with a known and recorded diagnosis. Now, of course, that's not everyone who's diagnosed. Sorry, that's not everyone who has dementia. We know that there are people who have dementia who don't have a diagnosis. And that's thought to be overall across all age ranges, it's about a third of people with dementia don't have a diagnosis. But it's also the case that people, if you like, kind of grow old with their young onset dementia. So you can have symptoms below the age of 65, you can be diagnosed below the age of 65, but then you're likely to live for several years with your dementia. And you may be over 65, but you've still got young onset dementia because it started when you're under 65. So Janet Carter, who's done a huge amount of work in this area, estimated recently that about 7% of all people with a recorded diagnosis were diagnosed below the age of 65. So we're already getting from a sort of 3% to 7% if we think about people who, if you like, who's sort of grown old or sort of gone past the age of 65 with their diagnosis. And if we extrapolate that from England to the whole of the UK, and we include undiagnosed people, what this means is that there might be as many as 70,000 people in the whole of the UK living with young-onset dementia, and that's often the number that the charitable organisations quote when they talk about the numbers of people who are affected. Clearly, if that's true, it means that the effective dementia diagnosis rate in YOD is significantly lower than it is across the board. So, 20,000 or so out of 70,000, that's not a very impressive diagnosis rate. But to be honest, the 70,000 is an estimate. I'm not sure we really do have a fantastic handle on what the actual number is. Now let's think about incidence. So here we've got from the CFAS studies that Professor Brain spoke about so wonderfully earlier today. And these are the incidence figures in the older age group, so from 65 upwards. And showing that just as in parallel with prevalence, we've seen a decline between the two epochs of the CFAS study in the incidence of dementia across the age range. But in fact, if we were to try and extend that line to the left, or below the age of 65, we don't have fantastic data to actually answer that question, like what is the incidence of dementia below the age of 65? So, and I think this was also Carol's group who did this work. There was an attempt to look at this, and we have to go back, nearly 20 years to this data, looking in Cambridgeshire in the sort of mid-2000s, and they came up with a figure of 11.5 cases per 100,000 person years in this sort of key at-risk middle-aged group of 45 to 64 years of age. And that is, if we just go back to the previous, so there you're seeing incidence per 1,000. So that would be effectively just over one case per 1,000 person years. So that's really right at the bottom of that graph of the y-axis. So this is obviously an uncommon thing to happen compared to the rate at which older people are getting dementia. And they estimated that the breakdown of this was within this sort of 11.5 cases per 100,000 people per year, about 40% would be Alzheimer's disease, about a third would be frontotemporal dementia, and about just under 10% would be Huntington's disease. Now, we'll see in a minute to the extent to which those predictions are borne out in what's actually going on in memory services. But they suggested by extrapolation across the whole of England and Wales that would amount to about 1,000 or so new cases per year, of which 450 or so would be frontotemporal dementia and 550 would be Alzheimer's disease. Now, we'll have a look in a minute about that, but what's actually being diagnosed in memory services. But I think you would agree that if we're talking about 1,000 cases a year, then divided evenly among all different memory services around the country, that means that each one is diagnosing only a handful of younger people with young-onset dementia each year. And so there's a question about expertise and how you generate expertise in doing something that might have to be done slightly differently than in older people if you're looking at a relatively low volume of cases per year in each individual centre. Now, what are the risk factors for young-onset dementia? Well, you've probably already seen this graphic today. It's from the Lancet Commission, the 2020 edition. And so really anything and these at the top are the modifiable risk factors for dementia. So anything that lowers the average age of onset of dementia, in other words, sort of brings forward the expression of the underlying neuropathology, is going to increase your risk of having young onset dementia. That seems intuitive to me. So, there isn't anything particularly magical about how people get young onset dementia. It is going to be through an accumulation of various types of well-known risk factors. But there are also others that are perhaps specifically relevant and not necessarily covered in the Lancet Commission because some of them are not modifiable. But so deprivation, I think there's good data, and I'll show you a little bit of that in a minute. Racial minoritization is a factor. So we know that people of Black and Asian minority ethnic origin get dementia at a younger age than white people in the UK, and in other societies as well, like the US. Learning disability is a very significant risk factor for young onset dementia, and in particular Down syndrome. And age, I mean, it might seem a bit odd to put age, but of course, people aged 60 to 64 are at a very significantly increased risk of dementia compared to people aged 45 to 50. So there is, even within the YOD sort of a demographic, there is a gradient over time. So the older you are within the YOD group, the more likely you are to get dementia. And of course, genetics, both sort of polygenic contributors and individual sort of deterministic gene mutations, which I'll say a little bit about in a minute. So this is some great work that Pasha Batongo and Charlie Marshall did at QMUL a couple of years ago, looking at dementia risk in a very ethnically diverse and quite impoverished area of East London. And on these plots, you can see, and sorry if they don't project brilliantly, that effectively the age of onset of dementia is left shifted towards the younger age groups by ethnic minority status and by deprivation. So this is I think this is quite, if any talk about YOD, I think we've got to acknowledge that certain people are at increased risk and think about how we might start to break down some of these disparities. So let's have a look at some data from Memory Service, some actual service level data. So this is from the 2019 National Memory Service audit that we did through the London Dementia Network. And in a paper that Irons and colleagues produced, looking at specifically comparing the young onset dementia cases and late onset dementia cases in the Memory Service audit cohort. And what we see is a few quite interesting observations. So whereas, as you'd expect, women outnumber men in people with late onset dementia, that's people who's received their diagnosis at the age of 65 or above, actually among young onset dementia, it's the other way around. So there are more men in the young onset dementia group. There isn't a signal for ethnic minority status in our data set. People with young onset dementia are actually less likely to live alone. It's quite interesting and interesting what people think about that and why that might be the case. And maybe what that's telling us that people who live alone who develop a young onset dementia are not getting diagnosed. There were quite strong differences in terms of alcohol consumption and smoking. Now that doesn't necessarily mean that everyone that the attributable risk factor for young onset dementia in our cohort for alcohol is very high. We know that alcohol consumption declines with age, so we could just be seeing an effect of age here rather than a specific effect of alcohol on causing a lot of the young onset dementia in the cohort. But these were quite interesting observations nevertheless. So does it matter clinically? Is this an important distinction? So I would say yes. I think we see overlapping but different clinical presentations from late life dementia. We see at the level of brain pathology overlapping the different pathologies. We see an increased prevalence of familial, in other words, genetic dementias. And of course, and no talk on young onset dementia should be without reference to this, we see a sort of slightly different a very profound set of psychosocial consequences of developing a life-limiting illness with accompanying cognitive and functional decline at a younger age. And I'll say a little bit about that at the end. Now, I think an important thing to say about what's going on in memory services is that age predicts something quite important in memory service. It kind of predicts what the underlying, what the ultimate diagnosis is going to be. And the reality is that most people aged under 65 who get into a memory service do not have dementia. In the 65 and over age group, most do. So GPs are really good at identifying people who are going to end up with a relevant diagnosis like MCI or dementia, who are age 65 and over, and referring them into memory services. So but somehow it doesn't work. It's not that process isn't quite working for younger people. And one of the things I'm interested in terms of the sort of the research that I've done is what is this this grey 60%, this other that people younger people sitting in memory services have, and in my view it's almost all of it will be functional cognitive disorder, but that's a label that is infrequently used at the moment across the NHS and particularly in memory services. And be interested to tease out why that might be. So I think in younger people, we are talking about a rather more complex and diverse case mix in a memory or cognitive clinic in the younger age group. So I think there is a large amount of functional cognitive disorder. I think, and colleagues in memory services can tell me whether they agree with this or not, but I think we see there's more psychiatric illness presenting with cognitive symptoms. We are seeing there is more alcohol and drug misuse among younger people with dementia, and obviously that then is a confounder in terms of trying to work out what's going on. We see a larger range of rarer organic causes of cognitive impairment, and of course learning disability is going to be an element. Some of it may be undiagnosed, and therefore people may come to, if you like, a standard community memory service and would not necessarily be being assessed in an LD specific service. In terms of the kind of subtype breakdown, so on the right is what a group of experts in the Dementia UK publication some years ago now predicted would be the subtype breakdown in the older population, which you can see Alzheimer's disease. They said Alzheimer's disease is going to be 60%, and we've heard from Carol Brain that is probably an oversimplification. But you can see the breakdown there: vascular following, and then mixed, and then all the others. Now, a few years ago, we looked at the case mix in our cognitive neurology service at St George's, obviously a highly selected population. But we looked at our under 65s, and what we see is that Alzheimer's disease is still the commonest cause, but it's only about a third. So it's about half of what we see in what we might expect in an older population. And the big purple group there is behavioral variant frontotemporal dementia. So that is a common diagnosis in cognitive neurology practice in the under 65s. Here's the data from memory services that took part in the 2019 audit. And actually, it's quite interesting. What you see here is that actually Alzheimer's disease is not 60% of the diagnoses that are being made across the board in English memory services. It's just under half, but it's still higher than in younger people. So Alzheimer's disease, again, it's still the commonest in younger people, but it's less of the pie than it is in older people. Vascular dementia, interestingly, turns out to be about the same. Alcohol-related dementia is diagnosed very infrequently in older people in memory services, but it's about 12% of younger people in memory services. And the other interesting thing, so mixed dementia is diagnosed much more commonly in older people. That's not a surprise. I think that's appropriate. And then frontotemporal dementia is more common more commonly diagnosed in the younger age group. But I still think that 7% is slightly worries me. That may represent underdiagnosis. It'd be interesting to know what people think, why that might be the case. Are people with FTD actually not being referred to memory services because they're not presenting with memory loss, and so people don't make that connection, or are they potentially being misdiagnosed as something else? So if you're practicing in the YAD clinical space, you've obviously got to get used to this kind of broader range of presentation. So just with an Alzheimer's disease, there's heterogeneity. In younger people, you're more likely to see posterior cortical atrophy, more likely to see a language-led presentation called logopenic aphasia or progressive logopenic aphasia. You're more likely to see frontotemporal dementia with its 3 variants, which are listed there. And clearly, you're going to see more alcohol-related dementia, and mixed dementia is pretty rare in younger people. Because you're seeing less amnestic Alzheimer's disease, you are more likely to have involvement of non-amnestic cognitive domains, which I've listed here, and be aware that some cognitive screening instruments don't probe these all that well. So you have to kind of, so that might be one of the reasons why we don't necessarily pick up on the sort of full spectrum of conditions that people have, because our instruments have been largely designed around picking up Alzheimer's disease. In terms of diagnosis, I'm not here to make a hard and fast rule about this, and the NICE guideline certainly doesn't say this, but I think it's reasonable to say that MRI is a bit preferable to CT in younger people for various reasons. So, you might be a bit more likely to do serial imaging in a younger person as part of the diagnosis, and you don't want to give a younger person lots of CT exposure. The signs have greater specificity in younger people, the radiological signs, because you're more likely to be dealing with a single pathology. And the subtle changes that you might therefore see have a bit more rule-in utility, rather than just using imaging to rule out non-vascular, non-degenerative mimics. And then something that is worth thinking about is that sometimes we are, in younger people, we are more likely to see a rarer disease, like a genetic form of Alzheimer's disease, like CADASIL, or even MS, which I occasionally have diagnosed, presenting de novo with cognitive symptoms. And the unusual patterns of white matter abnormality that are associated with each of those three conditions are more likely to show up on MRI than CT. Also, of course, a scan is only as good as the report that you get, and you probably want, given some of the things I've just commented on, you ideally want your scans reported by specialist neuroradiologists. We come to biomarkers, so functional and biomarker-based diagnostics like FDG PET or CSF, amyloid beta levels have better specificity in young people, particularly amyloid. It's in my opinion, above the age of 70, it really starts to lose its specificity, and you might end up potentially labeling someone as having Alzheimer's disease who hasn't got Alzheimer's disease. That's again a topic for another day. And obviously we want to use our arsenal of diagnostic tests to the best of our abilities, because we don't, to misdiagnose someone at a critical, juncture in life is a significant thing to do. So we want to get it right. There are genetic elements, and in the interest of time, I won't talk about this now, but be aware that small numbers of people, young people with dementia, with Alzheimer's disease below the age of 65 do have genetic mutations. And FTD is actually a significantly more genetic disease than Alzheimer's disease. And then occasionally you will come across genetic vascular dementia due to CADASIL. And I think it's worth thinking about and having an idea in your head, like who would I test and how would I counsel people about testing. I won't go through this for now because we're a bit short of time. That's a scan of CADASIL for your interest. And then, of course, just to conclude, we have to acknowledge the kind of diverse and very significant range of psychosocial issues that are brought up by young-onset dementia diagnosis, and think about how we support people through that. So something that's often quoted is a delay in diagnosis, and often you'll hear this cited, that it takes about 4 years for someone with young-onset dementia to get a diagnosis, as opposed to 2 years for someone with late-onset dementia. Well, the memory service audit suggests that if there is a discrepancy, that delay is at the pre-referral stage. In our data, the average time from referral to diagnosis is not actually very different between young and older people. So if there is a delay, it may be at the recognition stage within individuals themselves and families, or the point at which GPs agree to refer, and that's where the delay is happening. I think the health service actually is not offering people with young-onset dementia a poorer waiting time experience than older people. But then I've listed some of the things that then flow on from there, and that anyone who's involved in supporting people in clinic with YOD needs to be aware of. And in the interest of time, I won't list them all, but hopefully those of you in clinical practices, you'll recognise some of the issues that are raised there. Just one final slide, a bit of data. So we looked in the audit about the way in which cognitive stimulation therapy gets offered to young people in memory services. And it looks as though services are a bit less likely to offer it to young people. That's kind of interesting. Is there this sort of idea? Do people have this sort of rather stereotyped notion of what CST is, who CST is for? Interestingly, younger people are less likely to decline it if offered it. And again, services seem to be more inclined to think that CST is not appropriate for young people. So that's just worth thinking about. Are we denying young people certain types of evidence-based intervention? Okay, so in summary, young-onset dementia, it's about 3% of people with a recorded diagnosis, but maybe about 7% of all dementia. It does present more heterogeneously than late-life dementia. It does create a specific set of psychosocial challenges, and as a result, people affected by young-onset dementia need bespoke support, which I've not dwelt on too much today, but I definitely would make that case. So I'll pause there, and thanks very much for listening.